All right, Jarvis, let it rip.
Brilliant. Here's your next case. A 28-year-old male presents with acute right-sided low back pain that started 2 days ago after lifting a heavy box at work with poor body mechanics. He bent forward and twisted to the right simultaneously. Pain is localized to the right lower back and right buttock area, rating 6 out of 10 at rest and 8 out of 10 with movement. He's having difficulty with sit-to-stand transitions and walking. His goal is to return to work within 2 weeks. No previous history of back pain. He denies bowel or bladder issues, saddle anesthesia, fever, or unexplained weight loss. Go ahead and start your lumbar spine funnel examination. What would you like to assess first?
All right, first I can rule out cardiac syndrome because there's no bowel and bladder issues and there's no saddle area anesthesia, so that clearly kind of rules it out. But I'm going to dive into lumbar specific tests now. I want to assess straight leg raise test.
Good clinical decision. No hip indicators noted. So moving directly to lumbar specific testing. Here's his straight leg raise test finding. Straight leg raise test. Right side. Negative. Weighted movements and extension.
What about passive range of motion?
Here are his lumbar passive range of motion findings. Lumbar flexion. PR on. 75% of normal. Painless. Same as Aaron. Lumbar extension. PR on. 25% of normal with concordant. Right low back and buttock pain. Same as Aaron.
Okay, now we can rule out soft tissue issues. It's primarily due to like some kind of structural issues or mechanical issues. Now I want to actually test what was that? Is there any Gower sign on the patient when they move?
Side.
All right, great. So it's going to be primarily a L5 left-sided facet joint mechanical issue that creates that problem, and it might be caused by like bony degeneration or just the congruency of the bone or the vertebrae or the pars interarticularis. And my primary diagnosis would be mechanical dysfunction on the L5, and it's going to be stuck in that left side and probably an extension pattern of the left side. And I can't conclusively rule out spondylolysis because there was a positive Stork sign. So I'm just going to still put that in there, but we can always get that through imaging and clear it out. So after that, I want to actually that's my primary diagnosis.
Excellent clinical reasoning, Alex. Your final diagnosis is solid.
And for the outcome measures, I would probably do, since they have trouble standing up and walking, functional gait assessment and some muscle performance measures using their lumbar spine, maybe some sit-to-stands, 5 times sit-to-stand or 30 seconds sit-to-stand, or actual metrics using weightlifting. So I can use like a force dynamometer or anything that's related to gravitational force or force output.
Excellent functional assessment thinking. See, Alex, your outcome measures are spot on for the patient. 30 seconds sit-to-stand. Enjoy.